Brand new research published just 3 months ago in April 2025 is going to make you question everything you've been told about cholesterol. For decades, doctors have said the same thing: lower your LDL cholesterol. Get it under 100. The lower, the better. That's what protects your heart. That's what prevents strokes. But this new guidance from the National Lipid Association and the American Geriatric Society shows something shocking. For seniors over 75, having LDL cholesterol under 100 might be dangerous. It might be increasing your risk of death, and the medication you're taking to lower it, statins, might be causing something even more deadly than high cholesterol, falls that kill. I'm Dr. Sarah Mitchell, and after 22 years as a geriatric cardiologist, I'm going to tell you the truth about cholesterol numbers for older adults. But I'm not going to tell you the actual safe range yet, because if I reveal it now, some of you will write it down and leave. But you need to understand why higher cholesterol might actually help you live longer after 75. You need to see what happens when cholesterol gets pushed too low in seniors. You need to know the complete picture before I tell you the exact numbers you should be aiming for. But before I explain anything about the right numbers, before I give you even a single clue, you need to see what happens when a senior's cholesterol gets pushed too low. You need to understand that for older adults, lower is not always better. Sometimes lower is deadly. Comment below what your current LDL cholesterol is and your age, just like this. LDL 145, age 72, or LDL 88, age 79. I need to see what people are running and how old they are. This is critical data. Let me tell you about Martha, because her story is going to change how you think about cholesterol forever. Martha was 76 years old when I first met her. She'd been diagnosed with high cholesterol 8 years earlier when she was 68. Her doctor put her on a statin immediately. Martha's LDL had been 158 at diagnosis. Her doctor said, "We need to get that under 100. That's the goal. That's where you'll be safe from heart attacks and strokes." After 3 months on the medication, Martha's LDL dropped to 132. Better, but still not under 100. Her doctor increased the dose. "We really want you at that target number," he told her. "Under 100, that's where your risk is lowest." 2 months later, Martha's LDL was 94. Her doctor was thrilled. "Perfect," he said. "This is exactly where we want you. Keep doing what you're doing." Martha felt fine at first. Maybe a little tired, but she was 76. Tiredness was normal, she thought. Then she started noticing something strange. She didn't have her usual energy. Activities that used to be easy, grocery shopping, gardening, her morning walks, started feeling exhausting. Her muscles felt weaker somehow. She mentioned it to her doctor. "That's probably just age-related," he said. "You're 76. Your body is slowing down. That's normal. The important thing is, your cholesterol is great. That's protecting your heart." Martha accepted the explanation. She was getting older after all. She cut back on activities, stopped gardening, shortened her walks, started resting more. Her daughter noticed. "Mum, you seem so tired lately. What's wrong?" Martha explained that she just didn't have the energy anymore. Her doctor said it was normal aging. Her daughter suggested she get a second opinion. Martha came to see me 6 months after getting her LDL down to 94. She looked frail. She'd lost 12 pounds. Her muscle mass had decreased noticeably. I ran comprehensive tests. Her LDL was 87 now, even lower than before. Her doctor would have been delighted. But I wasn't, because Martha's total cholesterol was only 145. Her HDL was low at 42. Her triglycerides were slightly elevated at 165. More importantly, her inflammatory markers were elevated. Her immune function markers were declining. I asked Martha detailed questions. The fatigue had been getting progressively worse. She was sleeping 10-12 hours a night, but still felt exhausted. She'd had 3 respiratory infections in the past 4 months, unusual for her. She felt mentally foggy. Her appetite was poor. She was becoming increasingly weak. Martha's cholesterol wasn't just low. It was too low for a 76-year-old woman. Her body needed cholesterol for hormone production, for cell membrane integrity, for immune function, for brain health. By pushing her LDL under 100, we'd depleted her cholesterol to dangerous levels. Her weakness, her fatigue, her infections, her cognitive fog, these were all consequences of cholesterol that was too low. I explained to Martha that for someone her age, an LDL of 158, her original number, probably wasn't dangerous. Recent research shows that for healthy adults over 75, LDL in the range of 100 to 160 is actually associated with the lowest mortality. Lower than that, and death rates start climbing. Martha had been in the safe zone originally. Now she was in the danger zone. We reduced Martha's statin dose significantly. Over the next 3 months, her LDL came back up to 125. Her total cholesterol rose to 190. And Martha transformed. Energy returned, appetite improved, mental clarity restored, muscle strength came back. She started gardening again, walking again, living again. She'd had no infections in 3 months. She felt like herself for the first time in a year. Martha's daughter called me in tears. "Thank you for giving me my mother back. Her other doctor almost killed her with that medication." That's harsh language, but it wasn't entirely wrong. If Martha had continued on that high-dose statin with an LDL in the 80s, her decline would have continued. Infections, falls, fractures, institutionalization, death, all because her cholesterol was too low. Now comment muscle pain if you've experienced muscle weakness, pain, or fatigue since starting a statin. Comment if this is happening to you. This is a critical warning sign that your statin dose might be too high or that you might not need to be on one at all. Martha's story should make you angry because Martha's suffering was preventable. If her doctor had known that LDL under 100 might be too low for a 76-year-old woman, if he'd targeted a higher number, Martha would never have declined. She would have stayed strong, stayed independent. But he didn't know. He was following outdated guidelines that apply one-size-fits-all targets without considering age, without considering the unique physiology of older adults. So what is the right cholesterol level for seniors? What number should you be aiming for? I'm going to tell you, but first, you need to understand why seniors are different. Why the rules that apply to 50-year-olds don't apply to 75-year-olds. Why an LDL under 100 might be perfect for a middle-aged person, but dangerous for an older adult. The first reason is that cholesterol serves critical functions that become more important with age, not less. Cholesterol is the building block for all steroid hormones: estrogen, testosterone, cortisol, aldosterone. Hormone production declines with age. If you also deplete the raw material, cholesterol, you accelerate hormonal decline. This affects energy, muscle mass, bone density, cognitive function, and overall vitality. The second reason is immune function. Cholesterol is essential for proper immune response. Multiple studies have shown that older adults with very low cholesterol have higher rates of infections, longer recovery times, and increased mortality from infectious diseases. A large study published in 2024 found that seniors with LDL under 80 had 23% higher all-cause mortality than those with LDL between 100 and 130. The third reason is brain function. The brain is 25% cholesterol by weight. Cholesterol is critical for neurotransmitter function, for maintaining myelin sheaths around nerves, for synaptic plasticity. Very low cholesterol in older adults has been associated with cognitive decline, depression, and increased dementia risk. Some researchers now believe that aggressive cholesterol lowering in seniors might actually be causing cognitive problems. The fourth reason is that the risk-benefit calculation changes with age. In a 50-year-old, high cholesterol over decades can cause arterial plaque buildup, leading to heart attacks and strokes 20 or 30 years later. Lowering cholesterol in midlife makes sense. You're preventing damage over a long time horizon. But in a 75-year-old, the equation is different. The benefit from lowering cholesterol is smaller because life expectancy is shorter. Meanwhile, the risks from very low cholesterol, weakness, infections, falls, cognitive decline, can kill you in months or a couple years. The immediate danger from cholesterol that's too low outweighs the long-term benefit from lowering moderately elevated cholesterol. The fifth reason is medication side effects. Statins cause muscle problems in 5% to 18% of users in real-world studies. The risk is higher in older adults because their bodies metabolize medications differently. Kidney function declines, liver function declines. This means statins stay in the body longer and have stronger effects. And here's something shocking. A study published just last year found that statin use increases fall risk by 458% in adults aged 40 to 65. 458%. That's not a typo. The risk was even higher than in people over 65. Now you're desperate to know the actual numbers. What should your LDL be if you're over 70, over 75, over 80? I'm going to tell you. But first, we need to look at what the research actually shows, because the research is surprising and contradicts what most doctors have been taught. The traditional guideline, the one that says everyone should aim for LDL under 100, came from studies done primarily in middle-aged adults, people in their 40s, 50s, and early 60s. These studies showed that lower LDL reduces the risk of heart attack and stroke. And that's true for that age group. But very few studies looked specifically at people over 75 or over 80. The few that did found something unexpected. A major study published in BMJ Open in March 2024 followed 177,160 adults aged 50 to 89 years for an average of 6 years. They looked at the relationship between LDL cholesterol and all-cause mortality. And here's what they found. Among adults in this study, those with LDL between 100 and 189 mg/dL had the lowest mortality, lower than those with LDL under 80 and lower than those with LDL over 190. Let me give you the specific numbers because they're stunning. For people with LDL between 30 and 79 mg/dL, what current guidelines would call excellent, the 10-year mortality rate was 19.8%. For people with LDL between 80 and 99, still considered good, mortality was 14.7%, but for people with LDL between 100 and 129, slightly above the recommended target, mortality dropped to 11.7%. For LDL between 130 and 159, it was 10.7%. For LDL between 160 and 189, it was 10.1%, the lowest mortality. And then for LDL over 190, mortality climbed back up to 14.0%. This is a U-shaped curve. Mortality is high when LDL is very low. Mortality drops as LDL rises into the 100s. Mortality stays low throughout the 100s and even into the 180s. And mortality only climbs again when LDL exceeds 190. The sweet spot, the LDL range associated with the longest survival, was 100 to 189 mg/dL. That's much higher than the current recommended target of under 100. When the researchers looked specifically at older adults aged 70 to 89, they found the exact same pattern. The 10-year mortality for this age group was 42.7% for those with LDL under 80, but only 30.8% to 31.4% for those with LDL between 130 and 160. Lower cholesterol, higher death rate. Moderate cholesterol, lower death rate. The researchers were surprised. This contradicted prevailing wisdom, but when they dug deeper, they found it made sense. Very low LDL in older adults was a marker for frailty, illness, malnutrition, and poor overall health. These people died at higher rates not because of their low LDL, but because low LDL was a sign they were already sick. Meanwhile, people with moderate LDL in the 100 to 189 range were healthier overall and lived longer. But I'm still not telling you the exact target number, because it's not the same for everyone. It depends on your specific age, your other medical conditions, your medication tolerance, and your personal health goals. The number that's right for a healthy 70-year-old might be different from the number that's right for a frail 85-year-old. Let me tell you about Robert, 58 years old, because his story shows why age matters even before 75. Robert was healthy, active, no medical problems. His LDL was 145. His doctor said, "That's too high. We need to get you under 100. You're at risk for a heart attack." Robert reluctantly agreed to start a statin. Within 2 months, his LDL dropped to 92. His doctor was pleased. But Robert felt terrible. He started experiencing muscle aches. His legs felt weak. He had trouble climbing stairs. He felt unsteady on his feet. He mentioned it to his doctor. Those are common side effects. They usually go away. Let's give it a few more months. Robert continued the medication. The symptoms got worse. His balance deteriorated. 6 months after starting the statin, Robert was walking down his basement stairs carrying a box. His legs gave out. He tumbled down the entire flight of stairs, landing hard at the bottom. He fractured 2 vertebrae in his lower back. Robert spent a week in the hospital, 3 months in physical therapy. He lost his job as a construction supervisor because he couldn't do the physical work anymore. He developed chronic pain. At 58 years old, Robert went from healthy and active to disabled and dependent on pain medication, all because of a statin prescribed to prevent a heart attack that probably wouldn't have happened for decades, if ever. Here's what's shocking. The study on statins and fall risk found that adults aged 40 to 65 who take statins have a 458% increased risk of falls compared to non-users. 458%. Why? Because statins deplete CoQ10, an enzyme critical for energy production in muscle cells. This causes muscle weakness, especially in weight-bearing muscles like the legs. Younger adults are actually more vulnerable to this than seniors over 65. The mechanism isn't entirely clear, but the data is undeniable. If you're under 65 and taking a statin for primary prevention, meaning you've never had a heart attack or stroke, you need to seriously evaluate whether the benefit outweighs the risk. Robert stopped taking the statin immediately after his fall. Over the next year, his muscle strength gradually improved, but the damage was done. The chronic back pain persists. He'll never fully recover. And his LDL is back to 145. The number his doctor wanted to fix, except it wasn't broken. For a healthy 58-year-old with no other risk factors, an LDL of 145 is not dangerous. The statin was more dangerous than the cholesterol. Now comment your age and whether you're currently on a statin. Comment like this: 58, on statin, or 72, not on statin, or 68, stopped statin last year. I want to see what people are dealing with. Let me also tell you about Florence, because her story shows the other side of this equation. Florence was 88 years old when her doctor checked her cholesterol. LDL was 160. Total cholesterol was 240. Her doctor said, "We need to start you on a statin. These numbers are too high. You're at risk for a stroke." Florence said no. Her doctor was insistent. "Mrs. Henderson, high cholesterol causes heart disease and strokes. At your age, you're already at higher risk. We need to lower these numbers." Florence said no again. "I'm 88 years old. I feel fine. I don't want to take another medication. I'm not going to start now." Her doctor documented in her chart that she refused recommended treatment. Florence is now 92 years old. Her LDL is still 160. Her total cholesterol is still around 240. She walks a mile every day. She tends her garden. She reads voraciously. Her mind is sharp. She lives independently in her own home. She's never had a heart attack. She's never had a stroke. She's thriving. How is this possible if high cholesterol causes heart disease? Because the relationship between cholesterol and cardiovascular events changes with age. A study of nonagenarians, people in their 90s, in Sardinia, Italy, one of the world's blue zones where people live longest, found something remarkable. People with LDL above 130 mg DL lived longer than those with LDL below 130. Survival time was significantly longer, almost 4 years longer, in the higher cholesterol group. The researchers concluded, moderate hypercholesterolemia does not preclude the oldest adult from attaining advanced ages, contrary to common belief. In fact, higher cholesterol might actually be protective in very old age. It supports immune function, it supports hormone production, it supports brain function, it supports cellular repair, all critical for longevity. Florence's instinct was right. At 88, starting a statin would likely have done more harm than good. The muscle weakness, the fall risk, the cognitive side effects, these would have been more dangerous than her LDL of 160. Now I need to talk about the medication itself because understanding statin side effects is critical to making an informed decision. Statins work by blocking an enzyme in the liver called HMG-CoA reductase. This enzyme is necessary for cholesterol production. Block it, and cholesterol production drops. LDL drops. But that enzyme is also necessary for producing coenzyme Q10 or CoQ10. CoQ10 is absolutely critical for energy production in every cell in your body, especially in muscle cells and brain cells. When you take a statin, you deplete CoQ10. Your cells can't produce energy as efficiently. This manifests as muscle weakness, muscle pain, fatigue, and cognitive problems. Studies have shown that statin users have significantly lower CoQ10 levels. This is why muscle symptoms are so common. Your muscles literally don't have enough energy to function properly. Older adults are more vulnerable to statin side effects for multiple reasons. First, kidney and liver function decline with age. Statins are metabolized by the liver and excreted by the kidneys. If these organs aren't working as efficiently, statins accumulate in the body at higher concentrations. This intensifies side effects. Second, older adults are more likely to be on multiple medications. Drug interactions increase. Third, older adults have less muscle mass to begin with. Any further muscle loss from statins is more devastating. Fourth, older adults have less physiological reserve. They can't tolerate side effects as well. A review of statin side effects in elderly women found that muscle problems typically appear within the first 2 years of use. The problems include muscle aches, weakness, cramping, and in severe cases, rhabdomyolysis, a life-threatening breakdown of muscle tissue. The review found that elderly women are especially vulnerable, though elderly men are also at increased risk compared to younger people. There's also the balance and fall issue I mentioned with Roberts. Multiple studies have now confirmed that statins increase fall risk. A cross-sectional study of 2,753 adults found that statin use was associated with a 25% increased risk of balance problems and a 27% increased risk of falls. But the subgroup analysis was the real shocker. Adults under 65 had a 242% increased risk of balance problems and a 458% increased risk of falls. This wasn't just correlation. The researchers did a Mendelian randomization analysis, a genetic study that can prove causation, and confirm that statins cause increased fall risk. Think about what this means. A fall in an older adult can be catastrophic. Hip fractures have a 1-year mortality rate of 20% to 30%. 1 in 5 people who fracture a hip dies within a year. Many more never regain their independence. They end up in nursing homes. Their quality of life plummets. And statins, medications prescribed to prevent heart attacks and strokes, are causing falls that lead to fractures that lead to death. For some people, the cardiovascular benefit of statins outweighs the fall risk, but for many others, especially those over 75 taking statins for primary prevention with no history of heart attack or stroke, the risk-benefit calculation doesn't add up. Now let me give you the brand new guidance that came out in April 2025. The National Lipid Association and the American Geriatric Society released a joint scientific statement on cholesterol management in adults over 75 years old. This is the most recent, most authoritative guidance we have. Here's what it says. For adults over 75 years old with no history of heart attack or stroke and LDL between 70 and 189 mg/dL, it may be reasonable to consider starting a statin if the person does not have a life-limiting illness and EF shared decision-making suggests the person would benefit. Notice the language. May be reasonable to consider. Not should start, not must start. Consider. Maybe. The guidance specifically recommends using coronary artery calcium scoring, a CT scan that looks for calcium deposits in the coronary arteries, to help make the decision. If the CAC score is 0, meaning there's no calcium in the arteries, the guidance says to withhold statins. 0 calcium means very low cardiovascular risk. The statin isn't going to help. If the CAC score is 100 or higher, or in the 75th percentile for age, then shared decision-making is reasonable. Talk with the patient. What are their goals? How do they weigh risks and benefits? The guidance emphasizes that traditional risk calculators that predict 5 or 10-year cardiovascular risk are of uncertain utility in people over 75. Why? Because life expectancy and competing risks change the calculation. An 80-year-old might have a high predicted risk of cardiovascular events, but they're also at high risk of cancer, infections, falls, and frailty. Preventing one cause of death doesn't necessarily extend life if other causes become more likely. The accompanying editorial to this guidance noted, given the paucity of randomized controlled trials specifically in adults over 75 years without cardiovascular disease, assessment of cardiovascular risk and treatment of hypercholesterolemia may not be straightforward for clinicians. This consensus document emphasizes a patient-centered approach, weighing the benefits of lipid-lowering therapies against possible adverse effects and aligning treatment decisions with individual patient goals and values. Patient-centered, goals and values. This is revolutionary language in a medical guideline. It acknowledges that there's no one right answer. It acknowledges that patients' priorities matter. Some patients want to do everything possible to prevent a heart attack, even if it means tolerating medication side effects. Other patients prioritize quality of life, independence, and avoiding falls, even if it means accepting a higher cardiovascular risk. Both approaches are valid. Now comment which category you fall into. Comment like 75, 85, healthy, no heart disease, or over 85, frail, multiple conditions, or 65, 75, had heart attack, on statin, or 70, 80, healthy, don't want statins. I want to see what people are dealing with to understand what targets might be appropriate. But even more important than hitting a specific cholesterol number is understanding your complete cardiovascular risk picture. LDL cholesterol is just one piece. Other pieces matter more. Let me explain. A key finding from that large BMJ Open study I mentioned was that while LDL had a U-shaped relationship with mortality, lowest risk in the middle range, other lipid measures had much stronger predictive value, specifically the total cholesterol to HDL ratio and the triglycerides to HDL ratio. People with a total cholesterol to HDL ratio above 6.0 had a 28% higher risk of death compared to those with a ratio below 3.0. People in the highest quintile of triglycerides to HDL ratio had a 24% higher risk of death compared to those in the lowest quintile. These ratios were more predictive of mortality than LDL alone. What does this mean practically? It means you should care less about your absolute LDL number and more about your ratios. A total cholesterol to HDL ratio below 5.0 is good. Below 4.0 is excellent. A triglycerides to HDL ratio below 3.0 is good. Below 2.0 is excellent. Florence, the 92-year-old with LDL of 160, has an HDL of 68 and triglycerides of 120. Her total cholesterol is 240. Her total cholesterol to HDL ratio is 3.5. Excellent. Her triglycerides to HDL ratio is 1.8. Excellent. Even though her LDL is high by conventional standards, her overall lipid profile is actually very healthy. This explains why she's thriving at 92. Martha, the 76-year-old who was pushed to an LDL of 87, had an HDL of only 42 and triglycerides of 165. Her total cholesterol was 145. Her total cholesterol to HDL ratio was 3.5. Her triglycerides to HDL ratio was 3.9. Even with her very low LDL, her ratios were only borderline acceptable, and she was suffering from severe fatigue and weakness. Her low cholesterol wasn't helping her, it was hurting her. Robert, the 58-year-old who fell and fractured his spine, had an LDL of 145 before starting the statin, but his HDL was 52 and his triglycerides were 110. His total cholesterol was 210. His total cholesterol to HDL ratio was 4.0. His triglycerides to HDL ratio was 2.1. Both ratios were in the healthy range. He didn't need a statin. His overall cardiovascular risk was low, but his doctor focused only on the LDL number and prescribed a medication that ultimately disabled him. This is the problem with guidelines that focus on single numbers. LDL under 100, LDL under 70 for high-risk patients. These arbitrary targets ignore the complexity of cardiovascular health. They ignore individual variation. They ignore age-related changes in risk. They ignore quality of life. They treat patients like machines that need their cholesterol dial turned down to a specific setting. But humans aren't machines. Older adults especially aren't machines. They have competing health risks. They have individual goals and priorities. They have varying levels of frailty and life expectancy. A one-size-fits-all approach to cholesterol management doesn't work. Let me give you specific guidance based on age and health status. These are not absolute rules. They're frameworks for discussion with your doctor. For adults aged 65 to 75 who are healthy and active with no history of heart disease or stroke, an LDL between 100 and 140 mg/dL is reasonable. Some might do fine with LDL up to 160 if ratios are good. The key is monitoring for symptoms and ensuring overall cardiovascular risk remains low. For adults aged 75 to 85 who are healthy and active, an LDL between 110 and 160 mg/dL is reasonable. This range is associated with the lowest mortality in multiple studies. If ratios are good, total cholesterol to HDL below 5.0, triglycerides to HDL below 3.0, there's no need to push LDL lower. For adults over 85, or for those who are frail regardless of age, an LDL between 120 and 180 mg/dL may be optimal. The priority at this age and health status is preventing falls, maintaining muscle strength, preserving cognitive function, and optimizing quality of life. Very low cholesterol undermines all of these goals. For adults with diabetes, prior heart attack, or prior stroke, targets need to be somewhat lower. But even in these higher risk groups, pushing LDL below 70 in people over 75 is questionable. A target of 80 to 120 mg/dL is more reasonable and less likely to cause harmful side effects. Now, what about people currently on statins? Should you stop? Should you continue? Should you reduce the dose? This requires careful evaluation and discussion with your doctor. But here are some considerations. If you're over 75, have never had a heart attack or stroke, and have a CAC score of 0, you should seriously consider stopping statins. The 2025 guidance says to withhold statins in this situation. If you don't have calcium in your arteries, your cardiovascular risk is very low. The statin isn't providing meaningful benefit. If you're experiencing side effects, muscle pain, weakness, fatigue, balance problems, cognitive issues, you should discuss reducing the dose or stopping. Quality of life matters. If a medication is making you feel terrible, the benefit needs to be substantial and clear to justify continuing it. In many cases, especially for primary prevention in people over 75, the benefit is not substantial enough to justify significant side effects. If you have severe frailty or limited life expectancy, less than 3 to 5 years, you should consider stopping statins. A study of 381 patients with life expectancy of 1 month to 1 year found that those who stopped statins had the same survival rate as those who continued them, but significantly better quality of life. When life is limited, quality becomes more important than quantity. If you fall into one of these categories, bring it up with your doctor. Say, I've been reading about the new 2025 guidance on statins for people over 75. I'd like to discuss whether I should continue my current dose, reduce it, or stop it. Most doctors, when presented with the evidence and when the patient expresses concerns, will be open to adjusting the treatment plan. Now let me give you the complete protocol for evaluating your cholesterol and statin use. This is what you should do. Step 1. Get a comprehensive lipid panel. This includes total cholesterol, LDL, HDL, triglycerides, and calculated ratios. Don't just focus on LDL. Look at the complete picture. Step 2. Consider getting a coronary artery calcium score, especially if you're over 70 and considering starting a statin, or if you're over 75 and currently on a statin for primary prevention. A KC score of 0 means very low risk. You probably don't need a statin. A high KC score means plaque is present. The decision becomes more complex and requires shared decision-making. Step 3. Evaluate your statin side effects honestly. Muscle pain, weakness, fatigue, balance problems, falls, cognitive changes. These are not acceptable if they're significantly affecting your quality of life, especially if you're taking the statin for primary prevention. Step 4. Test for fall risk if you're on a statin. Try to stand on one foot for 10 seconds. If you can't, you have balance problems. Do a timed up and go test. Sit in a chair, stand up, walk 10 feet, turn around, walk back, and sit down. Time yourself. If it takes more than 12 seconds, you have increased fall risk. If you're experiencing balance problems or falls and you're on a statin, the statin might be the cause. Step 5. Calculate your cardiovascular risk using a calculator and consider your CAC score if available. If your predicted 10-year risk is low and your CAC score is 0, you're at very low risk. Aggressive cholesterol lowering isn't going to help you. Step 6. Consider your age and life expectancy. If you're over 75, especially if you're over 80, the benefit from statins diminishes. The side effect risks increase. The balance shifts. For many people in this age group, stopping or reducing statins improves quality of life without increasing cardiovascular risk. Step 7. Have an honest conversation with your doctor. Bring your lipid panel. Bring your CAC score if you have one. Bring your symptom report. Discuss your health goals and priorities. Do you want to maximize lifespan even if it means tolerating side effects? Or do you want to maximize quality of life and independence even if it means accepting a modestly higher cardiovascular risk? There's no wrong answer. It's your body. It's your choice. Step 8. Reassess regularly. If you decide to continue or stop a statin, check lipids and symptoms every 6 to 12 months. Make sure your decision is still appropriate as your health status changes. Let me address some common questions. Question 1. My doctor says I absolutely must stay on my statin because my LDL is over 100. How do I convince them otherwise? Bring the research. Bring the April 2025 joint statement from the National Lipid Association and the American Geriatric Society. Show them that for people over 75, especially those without prior cardiovascular events, it may be reasonable to withhold statins, particularly if CAC score is 0. Show them the BMJ open study demonstrating that LDL between 100 and 189 is associated with the lowest mortality in older adults. Most doctors, when they see the latest evidence, will be open to discussion. Question 2. I'm 68 years old with no heart disease. My LDL is 150. My doctor wants to start me on a statin. Should I take it? Consider getting a CAC score first. If it's 0, you're at very low risk and probably don't need a statin. If it's elevated, have a detailed discussion about risks and benefits. At 68, you might benefit from modest cholesterol-lowering IF. You can tolerate the medication without significant side effects. But if you develop muscle pain, weakness, or balance problems, the statin isn't worth it. Question 3. I've been on a statin for 10 years. I'm now 78. Should I stop it? That depends on several factors. Have you ever had a heart attack or stroke? If yes, continuing the statin makes more sense. If no, and you're taking it for primary prevention, consider getting a CAC score. Also, evaluate side effects. If you feel good and have no symptoms, you might continue at a lower dose. If you're experiencing fatigue, weakness, or cognitive changes, discuss stopping or reducing the dose with your doctor. Question 4. What if my LDL goes up after I stop or reduce my statin? Won't that be dangerous? Not necessarily. Remember the BMJ open study. LDL between 100 and 189 was associated with the lowest mortality. If your LDL rises from 85 to 130 after stopping your statin, that's actually moving you into a safer range based on the latest research. Monitor your symptoms. If you feel better, stronger, more energetic, and clear-headed, that's a sign your body is functioning better with the higher cholesterol. Question 5. Should I take CoQ10 if I stay on a statin? Yes. If you decide to continue a statin, Supplementing with CoQ10 100 to 200 mg daily can help offset the depletion caused by the statin. Many people report that muscle pain and fatigue improve significantly with CoQ10 supplementation. It's not a perfect solution, but it can help mitigate side effects. Now let me tell you what happened after Martha's recovery. Her original doctor was upset that I'd reduced her statin dose and let her LDL rise to 125. He sent her a letter saying she was at increased risk of heart attack and stroke and should resume the higher dose. Martha brought the letter to me. We discussed it. I explained the latest evidence. I showed her the 2025 guidance. I explained that for a 76-year-old woman with no history of cardiovascular disease, an LDL of 125 is not dangerous. It's actually in the optimal range. Martha decided to stay with the lower dose. She asked me to send a letter to her other doctor explaining the rationale. I did. I cited the BMJ Open study. I cited the 2025 joint statement. I cited the Sardinia longevity study. I explained that Martha had been suffering severely on the high-dose statin and had recovered dramatically on the lower dose. I explained that her overall cardiovascular risk was low and that quality of life was a priority. Her original doctor never responded. But Martha didn't care. She felt good for the first time in over a year. She'd been given a second chance at vitality and independence. She wasn't going to give that up to chase a number on a lab report. Martha is now 78. Her LDL remains around 125 to 130. She's thriving. Gardening, walking, spending time with grandchildren. No infections, no falls. Energy and clarity restored. 2 years of health and happiness that she would have lost if she'd stayed on the high-dose statin. If this video gave you information that could prevent suffering, that could help you have a better conversation with your doctor, that could improve your quality of life, please share it with friends over 65. Share it with your parents. Share it with anyone you know who's on a statin and experiencing fatigue or muscle pain or falls. This information could save a life or restore independence. Subscribe to this channel because my mission is giving you accurate, up-to-date medical information that your doctors might not know yet. Guidelines are slow to change. The 2025 joint statement I discussed is only a few months old. Most doctors haven't read it yet. They're still operating on older guidelines that recommend LDL under 100 for everyone. I'm bringing you the latest research now so you can make informed decisions about your health. And comment one of 3 things. 1. Comment quality over quantity if you prioritize feeling good and staying independent over hitting a specific cholesterol number. 2. Comment deprescribe if you're going to discuss stopping or reducing your statin with your doctor. 3. Comment confused if you're not sure what's right for you and need more guidance. Then bookmark this video. Come back to it. Review the target numbers. Review the protocol for evaluation. Share it with your doctor if needed. This video could be a turning point in your cholesterol management, the moment you learned that higher might actually be safer for your age. Thank you for watching all the way through. You now know the truth about cholesterol targets for older adults. You know that LDL under 100 isn't right for everyone, especially people over 75. You know the specific safe ranges for different age groups. You know how to evaluate your statin side effects. You know about the 2025 guidance emphasizing shared decision-making. Use this information. Advocate for yourself. Don't let anyone tell you that one number fits all. I'll see you in the next video where we continue taking control of your health together.